thumbs up if it goes live on Facebook. Good. All right, good morning everybody. Welcome to the PT on Ice Daily Show. It is Fitness Athlete Friday and I'm your host, Dr. Zach Long. Excited to talk to you today a little bit about hamstring tendinopathy, specifically proximal hamstring tendinopathy. I thought it'd be a good condition to review. Because right now I have 4 proximal hamstring tendinopathy patients on my schedule, and of those 4, all of them I am at least a second, if not third or fourth opinion on, and a couple of things have been missed in their treatment, in their examination, that I think has led to them having more chronic issues than they necessarily needed to have. And so I thought for us, this would be a good condition to review, as those of us that are treating highly athletic populations are going to see this quite a bit. So before we dive into discussing proximal hamstring tendinopathy, a couple live courses coming up that I want to mention because we're getting back at it. We're all masked up and gloved up at live courses, but we're getting back to what we love doing at ICE, and that's helping improve clinical skills and getting patients better. So we have our lumbar course July 11th in North Platte, Nebraska. Jeff will also be in Sydney, Nebraska, Justin will be in Sydney, Nebraska, July 25th, teaching total spine thrust. So you got 2 Nebraska courses if you're in that area of the country. July 11th, Justin will also be teaching total spine thrust in Santa Barbara, California. July 18th, we have our cervical management course in Tulsa, Oklahoma, and then cervical also the following weekend, July 25th, in Phoenix. So let's get to discussing proximal hamstring tendinopathy. So typically, this is going to be people dealing with deep posterior hip pain with activities such as running, lunging, squatting, and sitting. And that pain is going to be sitting right there at their ischial tuberosity. And I think what makes this condition so difficult for a lot of individuals is when you think of that location, right there at the gluteal fold, right at the ischial tuberosity, so often when somebody comes in having pain there, we immediately start thinking of other maybe more serious conditions that we're a little bit more worried about. For example, that's a very common area for people with lumbar radiculopathy to feel pain. And so of the 4 proximal hamstring tendinopathies I'm treating right now, one of those has low back pain and has this specific area of pain as well. And it's very hard to distinguish between, is that a lumbar radiculopathy going down there, or is it an ischial, or is it a proximal hamstring issue? We also get a lot of people that get the diagnosis of piriformis syndrome when they have pain there. That's a talk for another day. That's also a very common area if people are dealing with like sacroiliac joint issues to feel a little bit of pain there. And then kind of finally on my list there of differential diagnoses is femoral acetabular impingement or intra-articular issues in the hip. So femoral acetabular impingement or sometimes ischiofemoral impingement will kind of produce itself as a proximal hamstring tendinopathy. And so with those conditions, lumbar radiculopathy, intra-articular hip issues, typically we're a little bit more concerned about those versus a tendinopathy. And so I think a lot of times we miss these proximal hamstring tendon issues because we're thinking about these worse conditions. And of the 4 that I'm treating right now, one of those, I'll admit, I missed first day. That individual came in with a diagnosis of femoral acetabular impingement, came in with an MRI, kind of also finding labrum issues and a cam impingement. And so I got kind of my blinders on and didn't do a good job building out my hypothesis list there. And then when I went back and reviewed that case with Jeff Moore and Jordan Berry later, they both kind of smacked me alongside the head and said, you missed a very obvious proximal hamstring tendinopathy, because I got so focused on those imaging findings and the diagnosis given to this individual by 3 other medical practitioners. So it is a difficult one to diagnose at times. And I also find a lot of times that there's not specific mechanisms of injury here, which obviously a lot of times makes things easier, but also sometimes reproducing this individual's pain is a little bit more difficult. And so doing a really good, thorough evaluation following the symptom behavior model is incredibly important here. So let's dive into a few things specific with this. Number one, let's start with what are the causes that we typically see happen when somebody's dealing with a proximal hamstring tendinopathy. Most often this is going to be a training volume issue, like so many musculoskeletal issues. Somebody's doing too much for too long or progressing too rapidly. And very commonly we're going to see that happen with activities such as Sprinting, lunging, hip hinge work, yoga, Pilates, things where we really challenge the hamstring while the hip is in a lot of hip flexion. You'll also occasionally see this with accidents. So for example, I had somebody a little while back dealing with proximal hamstring tendinopathy that got a pedicure and was walking out of the pedicure shop wearing those little sandals that you get after getting a pedicure. I don't know what they're called. I don't get pedicures. And it was raining outside and those don't have any grip, so she slipped and went into a split, and that led to her proximal hamstring issue there. So obviously, as always, kind of look at training volume as far as a mechanism of injury there. But subjectively, the big thing you're going to find with these individuals is they're going to have increased pain with deeper angles of hip flexion. So think activities such as lunging, sprinting, sitting, especially if they're sitting on hard surfaces. Basically, as that hip goes into more flexion, we then put more compressive forces on the proximal hamstring tendon at the ischial tuberosity. Now, the difficult part with that subjectively, pain with increasing degrees of hip flexion, is that's the same exact stuff we're going to see with somebody dealing with intra-articular hip issues that comes to you dealing with femoral acetabular impingement. They're going to say when they sit, their hip gets irritated. They're going to say when they do lunges, step up, sprinting, that their hip gets irritated. And so that's where now we have to have both of those on our hypothesis list and do a really good job ruling in or out those issues. A couple of interesting things there to kind of fine tune a little bit more on sprinting, for example. Sprinting is one of those things that you will see a lot of individuals with proximal hamstring issues say that they have pain, but if you only ask about how running feels, you might not catch this. So they might say, no, I'm fine to go jog. If I'm at a slow pace, going out for a 3 to 5 mile run, it's fine. It doesn't bother me. It's not until I do tempo work and I start increasing my speed that starts to become bothersome. As we increase our speed, we're going to be engaging the hamstrings more. We're going to be going up into higher degrees of hip flexion. And so don't just ask about running. Ask about its correlation to that individual speed. So we get that information subjectively that again is a little bit cloudy. How do we go ruling out these other conditions? So how do we rule out lumbar radiculopathy and intra-articular hip issues? So we want to make sure we do a good lumbar active range of motion assessment with and without overpressure. And I think the really important one here is a lot of times people are going to feel pain when they do like a standing toe touch or multi-segment flexion. But what we should notice is that when you then add compression on top of that doesn't increase their symptoms at all. The tricky part there is when you do compression through the spine, you don't want to have your arm providing compression at the hips to be at the ischial tuberosity because you'll produce their pain by adding some compressive forces on that tendon. So make sure you're not pressing there. Lumbar segmental exam shouldn't produce that individual's pain. And then when you take the hip through passive range of motion, it shouldn't. So go hip internal rotation, external rotation, flexion, with and without overpressure. Those shouldn't produce the pain. The flexion might if it's a very sensitized proximal hamstring. Straight leg raise and slump tests sometimes will be positive because that proximal hamstring's so close to the sciatic nerve. Sometimes those chemical inflammation that you'll get there will lead to the sciatic nerve being a little irritated. So don't let that fool you because at times that will be positive. But then things like your Faber, your Fader test, those won't be positive with this as well. How do you go about diagnosing this? This is where you have to be really smart about your positioning on testing. So for example, as we add more hip flexion into any range of motion, flexibility, or manual muscle test, the more we're going to challenge the proximal hamstring. So a lot of times you'll find that if you do like a passive straight leg raise where you lock that individual's knee into extension and then take their hip up into flexion and look at their hamstring, sometimes that will produce their pain, sometimes it won't. But if you take their hip to 90 degrees of flexion with their knee bent and then extend the knee so that you probably are preloading the proximal hamstring a little bit more by having the hip flexion on board to start, sometimes that will be a little bit more sensitive. Where I really get into my diagnosis is more with manual muscle testing here. So if we start with manual muscle testing of the hamstring by progressively increasing the amount of hip flexion we see, we'll see that continually increases the amount of pain or the amount of weakness that individual feels. So if you go to a prone hamstring curl, for example, unless they're a very sensitive proximal hamstring injury, that very often won't produce their pain. Maybe they'll feel a little bit weak or a little bit of discomfort, but they won't say, yes, that is why I'm coming to see you. So they'll have a little bit of strength there. Then I'll go from prone hamstring strength at a 90-degree bend, so the hamstring's very shortened in 0 degrees of hip flexion, and we go to a seated hamstring curl where the hip's at 90 and the knee's at 90. So the hamstring's not super stretched, but we do have a good bit of hip flexion on board. You test their hamstring strength there, and they'll start to say, okay, that produces my pain a little bit more, but that's not really bad. You then go supine, and you take their leg and you go hips at 90 degrees of flexion, but now the knee is into more extension. Then you test their hamstring strength, and they'll say, yes, that's producing my pain more, and they feel a little bit weaker. And then as you add in more and more stretch to the hamstring, so the more you go into knee extension, the more that reproduces their pain. And then a lot of times I'll try to distinguish that a little bit too between glute activation and the hamstring by then having them go straight leg. And I do a resisted hip extension. So think of like in range of a passive straight leg raise, and then I have them drive their heel down into my shoulder, and that will typically produce their pain. But then if I let the knee bend and I put my shoulder below the knee and have them squeeze their glutes and drive their leg into me, that won't produce their pain so much. I know that's a little hard to describe and have you picturing. Hopefully you got that though. The more you challenge the hamstring with increasing degrees of hip flexion, the more you're going to sensitize that proximal hamstring, because the proximal hamstring is being loaded more when we add hip flexion. It's being loaded with compression a little bit more. One other thing that a lot of times I'll see in my objective assessment with these individuals is when we do a treadmill assessment of their gait, if it's a runner, because this very commonly does happen in runners, is we'll see them overstride and we'll see an anterior pelvic tilt. So if we're seeing an anterior pelvic tilt, as they go into flexion, we're going to be putting a little bit more compression on the proximal hamstring. If they're overstriding, that's going to lead to them having to engage their glutes a little bit more in a little bit more of an elongated position, and that will quite often produce their pain a little bit more. Treatment-wise, there's kind of 3 things that I really look for from a treatment perspective. Number 1 is going to be progressive hamstring loading, and we'll discuss that a little bit more in a second. Number 2 is going to be glute strength. So as I'm doing my assessment, I'm trying to determine, is there anything that indicates that they might have glute max weakness or glute minimus weakness, medius weakness? And if so, we're going to address that. I do think a lot of times we as physical therapists obviously get stuck in diagnosing everybody with glute amnesia or whatever terminology we want to use for it. And a lot of the patients that I see with proximal hamstring tendinopathy that have been treated by other physical therapists, they have all gone in the mindset or told this patient that your glutes are weak and your hamstrings are compensating. And so their entire rehab progression has been focused on just strengthening that individual's glutes, and that did not result in the abolishment of the individual's symptoms. So I think we don't need to get in the habit of just focusing on strengthening the glutes, that we need to instead focus on loading the hamstrings progressively and maybe doing some glute work if needed. Then also at times addressing maybe anterior pelvic tilt if they do that with certain positionings. So a lot of times, like for runners, if they're running with the anterior pelvic tilt, if you can cue them to a little bit more of a neutral pelvic positioning, then running becomes less symptomatic. So sometimes we end up doing some abdominal work with these individuals. But really it all comes down to progressively loading the hamstring. And so there are a couple different stages that we want to work these individuals through. If they're really sensitive or this is really early on in their rehabilitation, then a lot of times I'm starting them out with isometrics, because we know with some tendon issues that isometrics can have a good pain inhibition effect. So a lot of times I'll start there. I also start with doing exercises in lower amounts of compression or less amounts of hip flexion, because those are more tolerable for people with proximal hamstring issues. We'll discuss that in a second. The other thing I very commonly do in these early stages is I will do a lot of glute work in addition to that direct hamstring loading. And my thought process there isn't necessarily that we're working on decreasing their compensations there, like I quite often hear it described, but instead I'm thinking if I use the glutes a lot, I'm going to be pumping a bunch of blood into this area, and that's going to help wash out some of these chemical irritants that are sitting around in there and hopefully get them out of this early stage a little bit quicker. So I look at that as more just a blood pump to the general area. As we're loading the hamstring, as we go through the course of the rehabilitation process, we're going to go from exercises that challenge the hamstring and less hip flexion and progress it up to more and more hip flexion. So early on in that rehab process, the exercises I'm thinking of doing here are prone hamstring curls because the hip is an extension. Nordic hamstring curls because again, we're not challenging the hip by flexing it very much with Nordic curls, and slider curls. So the individual has their heels on sliders and they're doing like a glute bridge and extending their knees and flexing their knees. So those really work the hamstring muscle belly itself without challenging the proximal hamstring a considerable amount. And we just kind of find what's the level of loading that this individual tolerates. I typically follow kind of the Silvernagle pain model here of I want to produce your pain a little bit, maybe finding like a 3 out of 10 pain as we exercise, but I don't want that pain to last more than 24 hours. And we do these every other day or 3-ish days a week so that we load that hamstring. We load it to a point that we know that we're going to challenge the body to stimulate healing and growth, but then we give it some time to recover. And so those are kind of what I start with. As we progress and they become a little bit more tolerant of hip flexion, then we can move to exercises such as hip thrust. So we can do hip thrusts with their back elevated. We can do hip thrusts with their heels elevated. We can do step-ups and Romanian deadlifts. So very commonly I'll do Romanian deadlifts where we do it to a limited range of motion. So maybe I'm not having that individual go through their full amount of hip flexion. Maybe we're finding, with this amount of weight, how much hip flexion can you go through while creating that 3 out of 10 pain? And then our progression there isn't always necessarily adding weight. Sometimes it's adding range of motion there. That just depends on that individual and how they present in the clinic. As we progress to more and more higher levels of hip flexion, we can do things like seated hamstring curls. I don't go seated hamstring curls super often because a lot of times I feel like when we're hip flexed and sitting on the ischial tuberosity plus adding in the hamstring, sometimes that becomes very irritating because you have compression from the hip flexion as well as from actually sitting on the ischial tuberosity. But some individuals like that better than another exercise such as single leg deadlifts. So single leg deadlifts challenge the proximal hamstring quite a bit. Very often with these, I don't like single leg deadlifts where we let the other leg go up in the air because so many individuals are then more challenged by their balance rather than loading of the hamstrings. And so a lot of times I'll do like a kickstand single leg deadlift. So we keep the back leg on the ground so that it helps with balance a little bit, or a landmine single leg deadlift. But really what I ultimately try to get these individuals doing is one of two exercises towards the end stages of the rehabilitation. Either the glider, which you can search for. The glider was published, and I think it's called the Askling protocol. I may be wrong if it's that protocol or a different protocol, but it's essentially very similar to the single leg deadlift. But it really loads the proximal hamstring up. You can Google that exercise. I don't even know how to begin to describe that. But another exercise I really like is a reverse lunge. So we talked earlier, lunges are very commonly something that will produce these individual symptoms. I like to do a reverse lunge, but with a little bit of a twist to it. So typically if an individual does a reverse lunge, they allow their front leg, which is the one we're going to be working, to go forward. They allow that knee to translate forward. Well, when I do this to load a proximal hamstring, I like to keep a vertical shin angle or even a negative shin angle. So as that individual goes back, rather than the knee coming forward, if this direction was forward, I like to keep the knee actually behind the ankle joint. And as they do a reverse lunge, that will really, really load that hamstring glute connection, and they'll really feel that proximal hamstring be loaded up. And that becomes a really good exercise to challenge the hamstring in those end stages of somebody's rehabilitation. And I've had a number of times over the last few years where I saw individuals that actually went through a good progression of proximal hamstring rehabilitation and kind of got back to 80%, but never back to 100%. And when I incorporated things like that glider exercise and like that reverse lunge, that was the key to actually build up those end stages of strength in the proximal hamstring to finally get them through that. So I hope this review on proximal hamstring tendinopathy is helpful for you. Again, it is a challenging condition at times when it shows up in the clinic, but hopefully this rehab progression and kind of what we see subjectively and objectively helps you out so that you don't miss these in the future. Hope everybody has a great 4th of July weekend. Stay safe, and we'll see you next time.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.